Hi, everybody. My name is Louise Bacon, and I'm going to be starting us off here on this webinar. Thank you for joining us today. So I will be talking about gastroesophageal reflux disease. And if you could please save your questions until the end, we'll answer all of them. All right. So the question of today is, what is GERD, or also known as gastroesophageal reflux disease? And essentially, this is a group of symptoms that occur as a result of acid in the stomach refluxing back into the esophagus. And I have a little diagram here that kind of demonstrates what's happening. And so I'm going to turn your attention to this area that I'm pointing at with my arrow, which is the lower esophageal sphincter. And essentially what happens with reflux is that sphincter becomes incompetent and no longer functions normally to keep acid in the stomach, and it's allowed to go up into the esophagus. The stomach is designed to handle acid. It creates acid. The esophagus is not, and it actually is very delicate tissue, and so this actually causes damage to the esophagus. So I've listed some common symptoms that patients present with. The most common ones are heartburn, burning chest pain. Some people feel like they can taste acid in the back of their mouth, persistent sore throat, hoarseness, chronic cough or asthma symptoms, and then difficulty swallowing. So there are several things that we can do in our way to diagnose gastroesophageal reflux disease. It usually starts with the GI doctor, and that's when they do either an EGD or it's also called an upper endoscopy. And so I have a picture on the next slide that I'll go over, and I'll go into a little more detail. The other study that we sometimes do is called a pH Bravo study, a special X-ray called an esophagram, and esophageal manometry, which evaluates the motility of the stomach, or excuse me, of the esophagus. Okay, so I have some diagrams here, and you turn your attention to the one that says upper endoscopy. So that is a procedure that GI doctors do. And essentially, they're sticking a long camera down your throat, and they're able to look into your stomach and the first part of your small intestine, which is called the duodenum. And so that's a very important study because they're able to identify two things that are helpful. Number one, they're able to identify if there appears to be any damage in the esophagus as a result of reflux. The other thing is that they're able to help identify if somebody has what's called a hiatal hernia, which is where some of the stomach is actually going into the chest, and that also can contribute to having reflux or an incompetent lower esophageal sphincter. The Bravo pH study is a test that's done with the use of a special wireless capsule, and that is sometimes placed during an upper endoscopy. And they implant the capsule at the lower part of the esophagus. And what that capsule does is it's basically checking the pH of the lower esophagus. So if somebody has acid reflux, it's going to be getting pressure, or it's going to be getting readings that suggest that it's a very acidic environment. And then after a few days, the capsule usually falls off and it passes through your digestive system and you poop it out. The other study is called an esophagram. So this is a special X-ray, and with this study, essentially a radiologist has a patient drink contrast, and as you're drinking the contrast, we're shooting X-rays, and in real time, we're able to see what's happening when you swallow. And so they usually shoot one with you standing up, and we're able to trace everything going down into your stomach. And if somebody has reflux, then we're going to see the contrast kind of backsplash into the esophagus. And then they also usually get an imaging of somebody laying down and swallowing, because a lot of people will have reflux symptoms actually if they lay down after eating. The final test is an esophageal manometry. And this is not something that I routinely order, but there's definitely special situations where we will order it. So an esophageal manometry test basically checks the motility of the esophagus to make sure that it's functioning correctly. So a trigger that would make me want to order this for somebody would be if they complain of having difficulty swallowing or feeling like food gets stuck. That can sometimes suggest that there's a motility issue. And this is an important test because it kind of helps determine what kind of surgical procedure somebody is going to be a good candidate for. So anytime somebody has reflux, a good place to start without, doing aggressive interventions like surgery, or to do basic dietary lifestyle changes. And so some example of lifestyle changes would be weight loss, try not to eat late at night, avoiding tobacco. If you have issues with reflux when you go to bed, there are special wedge pillows, or sometimes sleeping with 2 or 3 pillows and keeping your head elevated helps. As far as dietary changes, trying to avoid foods that increase acid. And that's going to be things like caffeine, citrus foods, tomato sauce kind of things. And then also avoiding foods that decrease the pressure of the lower esophagus, and that's going to be fatty foods and peppermint. And then the final dietary change you can make is avoiding large meals. So the medical treatment of gastroesophageal reflux disease pretty much falls into 2 categories of medication. The first one, they're called proton pump inhibitors. And these medications block several pathways of acid production within the stomach. They do suppress acid production more effectively than histamine blockers. And examples of these are going to be omeprazole, also known as Prilosec, pantoprazole, also known as Protonix, esomeprazole, also known as Nexium, lansoprazole, also known as Prevacid, and dexlansoprazole, which is also known as Dexilant. The second class of medication is called histamine or H2 blockers. And these lower acid secretion by targeting the histamine receptor. And some examples of these are going to be famotidine, also called Pepcid, ranitidine, also called Zantac, and cimetidine, also called Tagamet. Now, about 20 years ago, when surgery to fix acid reflux was pretty morbid, the medications were very popular. But as a result of people being on these medications for several years, we're now definitely starting to see some long-term side effects of this, which are not very good. And this has led to some controversies with medical management. And, the controversy is really and truly, should people be on this medication for more than a year? So I'll start first with the proton pump inhibitors. So there definitely has been shown to be an increase in the risk of C. difficile infection, which that would lead to diarrhea. High doses and long-term use for more than a year can increase the risk of osteoporosis-related fractures. And it's also been associated with low levels of vitamin B12 and magnesium and chronic kidney disease. And then histamine blockers tend to have side effects of diarrhea, constipation. It can also cause colitis, ringing in the ears, and dry mouth. And so because a lot of these long-term side effects, there has been kind of this change where now surgery is becoming more popular because people don't want to be on these medications. So the surgical treatment of GERD. So years ago, again, surgery wasn't popular because it was very morbid and we didn't have a lot of the technology that we have nowadays. So nowadays, the treatment of the surgical treatment is exclusively minimally invasive. I have some pictures here of, so basically we do small incisions and we stick a camera and we're able to do things in such a way that the post-op pain and the recovery are significantly less. And the other nice thing about if you do surgical treatment is that there's no further need to be on any medication. As far as the treatment options for surgery, it really kind of falls into 2 classes. The first one I'm going to talk about is fundoplication. And there's 3 different kinds of fundoplications that we do. They all pretty much work the same way, and we're basically using the stomach to create a valve around the lower esophageal sphincter, and this helps to prevent reflux. The most popular type of fundoplication is called the Nissen fundoplication. And that one is where we basically take the top part of the stomach and we completely wrap it around the esophagus. The second one, which is called the door fundoplication, is where we take the top part of the stomach and we only wrap it around the front part of the esophagus. And then the toupee fundoplication is we're basically going from behind the esophagus, and we're instead of doing a complete wrap like the Nissen, we do leave a little bit of the front part of the esophagus open so that you're not going to have as much restriction. The second option for surgical treatment that has become very popular within the last 10 years is magnetic lower esophageal sphincter augmentation, which is also called the LINX. And as you can see in the picture, the LINX is literally a ring of magnets, and it's about the size of a quarter. And it's almost like a little necklace that we put at the bottom part of the esophagus. And it basically works as a valve. So, you know, when somebody is not eating anything, it helps keep the esophagus closed so that acid in the stomach cannot go into the esophagus. But then if you eat food, the LINX will actually open up to allow food to pass. And then as soon as the food passes, it closes again. And so that way you're not going to get reflux. Some insurance companies still consider the LINX to be experimental because it's only been around for less than 10 years. And so I would probably say that more patients would get this done, except that it, like I said, it's insurance driven. Possible complications after surgery include dysphagia or difficulty swallowing. I would say that this is more likely to happen with the Nissen fundoplication or the LINX. And that's where doing some of these tests that we mentioned in the beginning, in particular the esophageal manometry, are really helpful, because if I can identify ahead of time that somebody has a motility disorder, then we know that they're not going to be a candidate for either of those options. Another possible complication after surgery is called gas bloat syndrome. And this pretty much only occurs with the Nissen fundoplication because we're completely wrapping the bottom part of the esophagus. And so what happens with gas bloat syndrome, if somebody were to drink a carbonated beverage, for example, you may get the feeling that you need to burp, but then you can't because you now have a valve that prevents you from being able to do that. And it's a very uncomfortable feeling. So that's something that we definitely warn patients about before they have a Nissen fundoplication. The other thing that can happen with a fundoplication is that over time, as things move, it can slip. And so that can lead to dysphagia or feeling like you're having difficulty swallowing, or it could also make you feel like you're having reflux again. And if that happens, then that has to be surgically corrected. And then the final thing that can happen, and this is a potential thing that can happen with the LINX, is that if it's placed too tight around the esophagus, is that it can actually start eroding into the esophagus. And if that happens, you know, that has to be surgically removed and the esophagus has to be repaired. Long-term complications of gastroesophageal reflux disease include stricture, which is basically getting scarring in the lower part of the esophagus from damage. And it basically narrows the esophagus and makes it difficult to eat. The other thing you can get is a Schatzki's ring, which is basically a little band of scar tissue, which again causes difficulty with swallowing and the sensation of food getting stuck. And then Barrett's esophagus is basically when you've had prolonged exposure of the esophagus to acid, it damages the cells in the esophagus and they start transitioning into other types of cells. And this can be a precursor to esophageal cancer. So this is a really big deal. And when someone has been identified as having Barrett's esophagus by their gastroenterologist, they absolutely need to be started on at least medication, and they have to have, you know, frequent surveillance just to make sure that, which includes biopsies to make sure that nothing is progressing to cancer. And then the most dreaded complication of gastroesophageal reflux disease is esophageal cancer. Any questions?
Thank you. Thanks everyone for joining us this afternoon. Thank you, Dr. Bacon, for such an excellent presentation. I think it's a perfect lead into the second part of the discussion, in part because what Dr. Bacon alluded to was that, lifestyle modification and medical management is the mainstay of treatment for the initial presentation of acid reflux. I think one of the societal problems, however, is that many of these medications are available over the counter. And so quite a few patients actually initiate their own treatment for any extended period of time without ever going to see a primary care doctor or even seeing a gastroenterologist. And so I think it's a very important question to ask yourself, is this heartburn or is it something more? Because quite a few patients will self-treat for an extended period of time and could possibly miss something more significant. For those of you that do not know me, my name is Ledford Powell. I'm a thoracic surgeon, board certified. I've been in practice for 17 years, a little bit more. Did my residency training locally at UC Irvine and my fellowship training at UC San Francisco in cardiac and thoracic surgery. My practice focuses heavily on minimally invasive thoracic surgery, chest wall disease, chest trauma, pediatric thoracic surgery, benign and malignant disease of the lungs and pleura, as well as minimally invasive esophageal cancer. Most of my focus at UCSF was on esophageal cancer. Esophageal cancer, for the most part, is not one of our most common malignancies diagnosed in the United States of America. That would be breast cancer, colon cancer, prostate cancer. Esophageal cancer only accounts for about 1% of all cancers diagnosed in the United States. But it does have a significant impact on our healthcare system, in part because of the stage at which it is typically diagnosed. According to the American Cancer Society, about 19,260 new esophageal cancer cases will be diagnosed in 2021. The overwhelming majority of those will be in men, less frequent in women. And our two main types of malignancies are adenocarcinomas, which is extremely common in the United States, and squamous cell carcinomas, which to be less common in the US, although we are seeing it in increasing frequency. But this cell type is typically seen in regions of Asia and India and Iran. The overall survival of esophageal cancer has improved significantly. Several decades ago, the overall survival would have been quoted around 5%, but with advances in technology, diagnostic studies, treatment, the overall survival is over 20%. And 20% may not sound like a great number, but that's looking at all stages of disease. And in comparison to some of the more common malignancies diagnosed in the US, 20% actually is a very respectable overall survival. But what are the risk factors for esophageal cancer? And the reason why when we were talking about putting this webinar together, we decided to put esophageal cancer and acid reflux together is because you will notice a lot of similarities between what the risk factors are for esophageal cancer and what the risk factors are for acid reflux. But our older patients, as we get older, the muscles begin to relax in our esophagus. That increases our risk of exposing the esophagus to stomach acid, thus increasing that risk of esophageal cancer. Alcohol consumption, heavy alcohol consumption also associated with esophageal cancer. Diet, as Dr. Bacon already alluded to. Certain esophageal conditions, which she mentioned in her talk, predisposes the esophagus to dysplasia and subsequent esophageal cancer, Barrett's esophagus being the most common. Gender, much more common in men. Obesity, in part because of that increased pressure in the abdominal cavity, which sort of forces the lower esophageal sphincter open, will increase your risk of esophageal cancer. And then tobacco exposure, which I think is pretty much linked to almost every cancer, is no different. It increases your risk of esophageal cancer as well. With regards to gastroesophageal reflux disease, I put next to this 14% symptomatic. And the reason why I wanted to hone on that a little bit is that one of the most common complaints, especially in our high intensity, fast paced, stressful society, is heartburn. About 14% of patients that have severe gastroesophageal reflux disease symptoms and severity, we do have severity scores that we use as far as frequency, intensity, and relief of symptoms with medications. About 14% of patients with severe gastroesophageal reflux disease will subsequently be diagnosed with esophageal cancer. That being said, 50% of patients diagnosed with esophageal cancer will not have severe reflux symptoms. They'll actually only have mild to moderate symptoms, which quite honestly, most people will treat with over-the-counter medications, never see their primary care doctor, never see a gastroenterologist, and subsequently could potentially allow an early stage malignancy to advance to a stage that will no longer benefit from surgical intervention. The signs and symptoms of esophageal cancer can vary from chest pain, weight loss, esophageal bleeding, which will usually get the patient into the doctor's office, usually translates into black stools, frequent vomiting and hiccups, trouble with swallowing. But as of today, there are no screening tests that can be performed for esophageal cancer. Unlike screening for breast cancer, prostate cancer, colon cancer, screening for esophageal cancer does not exist. So how do we diagnose and stage esophageal cancer? Some of these are similar to the workup that we do for gastroesophageal reflux disease. The only difference would be initially many of the patients are presenting with reflux symptoms. Many of them will have already had a barium swallow or an upper GI series, which may suggest an abnormality. An esophagoscopy, abbreviated EGD, which would be done by our gastroenterologist. If there is an abnormality, or sometimes if there's no significant abnormality, but a high concern, a directed biopsy or random biopsy can be performed in a high-risk patient to try to diagnose malignancy or occult malignancy. Once the malignancy is diagnosed by biopsy and confirmed, then we move on to staging, and we have a series of tests that we do as a routine. Part of that is a CT scan of the chest, abdomen, pelvis. That's more so to give us information about whether the lymph nodes are involved, whether if they're spread to other parts of the body. PET CT scans are performed as well to give us additional information for abnormalities outside of the organ of interest. An MRI of the brain if we believe that the disease is advanced in stage. But if we do believe that the patient is a surgical candidate, then an endoscopic ultrasound has become an extremely critical part of the staging of these patients. What the endoscopic ultrasound does is that, it allows us to visualize the tumor, mark the location of the tumor in the esophagus, measure the depth of the tumor going through the esophageal wall, and then also give us some information about whether lymph nodes around the esophagus are involved, if they appear to be enlarged on the ultrasound. Also distant lymph nodes, whether those are involved, and then the opportunity for the gastroenterologist to biopsy those lymph nodes at the time of the endoscopic ultrasound. Combining all of this information allows us to stage the patient's esophageal cancer and then have a patient-physician discussion about what the treatment options would be. The treatment options for esophageal cancer varies depending on the stage of the disease, depending on the health of the patient. There are endoscopic treatments. Endoscopic mucosal resections are sometimes reserved for patients that would represent high-risk surgical candidates. If the patient is further advanced in disease, then usually combined chemotherapy, radiation therapy, and some immunotherapy is offered to these patients. In patients that have local disease or local regional disease, surgery may be an option. Most of the patients will have treatment prior to surgery, which tends to be a combination of chemotherapy and radiation therapy. Those patients will go on to have repeat imaging to assure that there has been no progression of disease during this treatment period. And then those patients that have showed stable to improved disease would be deemed surgical candidates. And then we'll have a discussion about what surgery would look like. Surgery for esophageal cancer comes in various forms based upon the stage of the disease, the location of the tumor, and the cell type. Most of the operations that we perform are done as a subtotal esophagectomy. So you can either remove the entire esophagus, and just a brief, quick anatomy. The unique part about this organ of the esophagus, it actually traverses 3 different regions of the human body. So the upper portion of the esophagus sits in the neck, and then you have the middle portion of the esophagus that sits in the chest, and then you have the lower portion of the esophagus that sits in the upper abdomen and then attaches to the stomach. Considering that the overwhelming majority of esophageal cancers in the United States of America are adenocarcinomas and are related to acid reflux, we see a large number of patients with lower esophageal cancer. These patients can receive curative treatment with a subtotal resection, where the thoracic esophagus is resected along with the upper portion of the stomach, and then the stomach is then moved into the chest and connected in the chest. In patients that have squamous esophageal cancers or cancers that are in the middle to upper portion of the esophagus, those patients will require a total esophagectomy. We refer to that as a 3-incision esophagectomy, where the esophagus is disconnected and divided from the neck, usually through the left side, and then dissected from the chest, usually through a videoscopic approach in the right chest. And then the lower portion of the esophagus and the upper portion of the stomach is removed through a laparoscopic approach. Because of the number of fields that are traversed at the time of this surgery, it is beneficial to have skilled surgeons from different subsets work together on this operation. Dr. Bacon and I have an excellent experience performing this operation together. She performs the abdominal portion operation through a laparoscopic approach, and then the thoracic portion of the operation is performed by myself using a videoscopic approach. And then that allows us to achieve effective eradication of the tumor with a complete lymph node dissection and pretty fast recovery for our patients. What you're seeing here on the left side of the screen is the abdominal portion of the operation being performed, the tumor sitting in the distal part of the esophagus. And then here is the chest portion. And again, the location and size of the incisions vary, but this is fairly representative of what typically occurs, is that we use a 5mm scope that is positioned on the side of the patient, and then 2 working incisions that vary in size from 5 to 10 millimeters in size towards the front. Sometimes we will use that lower incision depending on the location and size of the tumor. Sometimes we do not need to use that lower incision. But ultimately what we achieve is complete resection of the thoracic portion of the esophagus, all the way up to the uppermost portion of the chest. And then we take the lymph nodes along with the esophagus as part of the cancer operation. As far as what the patient experiences, the patient comes in the day of surgery. The operation is performed in one setting. Some facilities would do it in 2 settings. We do it in 1 setting. The average operative time is around 4 hours. It is all done through a minimally invasive approach. The average length of stay in the hospital is about 1 week, and most of that week is really allowing the patient to recover from the operation and then study the esophagus around 5 to 7 days after the procedure has been completed. If the diagnostic study that we use to evaluate the esophagus, which is usually an esophagram where the patient drinks some chalky tasting contrast, we take images, the esophagram that Dr. Bacon showed you pictures of earlier. And if that shows that the esophagus is intact and there is no evidence of contrast outside of the lumen of the esophagus, then we start the patient on a diet immediately. At that point, everything moves fairly quickly. Patients are usually home in about 48 hours after starting their diet. We send them home on a slightly modified diet to allow for things to heal, just because things are still a little bit irritable. But ideally on a regular diet within a couple of weeks, sometimes supplemented by feedings through a jejunostomy tube, which is a feeding tube placed in the small bowel at the time of surgery by Dr. Bacon. The overall 5-year survival varies depending on stage. This is a clip from the American Cancer Association using the SEER data on the reported 5-year survival. And just to clarify, because I get asked this question by many patients, 5-year survival is just the length of time that we follow patients. The number of patients that continue follow-up after 5 years is so small that we cannot get any reliable data. So we only report out to 5 years. But for localized disease, that is tumors that are limited to the esophagus with little to no nodal involvement, the 5-year survival is 47%. Regional, when there is invasion in surrounding structures or heavy nodal buccal involvement, those patients will usually get some form of chemotherapy, radiation therapy, followed by surgery, and sometimes additional chemotherapy and radiation therapy afterwards. That 5-year survival is less, around 25%. And then patients that have distant disease, these are patients that are outside of the realm of surgical intervention and benefit mostly from chemotherapy plus or minus radiation therapy. Their 5-year survival is 5%. Overall, 5-year survival has improved significantly. As I mentioned earlier, several decades ago, overall 5-year survival was 5%. And now we have overall 5-year survivals in excess of 20%. And our local data actually is even better than the national SEER data. Thank you for allowing me to talk today. Do you have any questions for me?